Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the deputy editor of JAMA Health Forum.
JAMA Health Forum is a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest author today is Dr. Hyunjee Kim, a health economist and associate professor at Oregon Health and Science University. She is focused on Medicare and Medicaid, long-term care, and the intersection of extreme weather events and health in her research. She is the lead author of a new study in JAMA Health Forum titled Association of Heat Waves with Adverse Health Events in the U.S. Among Dually Eligible Individuals. Welcome, Hyunjee.
Hi, everyone.
Dr. Jose Figueroa is an associate professor of health policy and management at the Harvard T.H. Chan School of Public Health and an assistant professor of medicine at Harvard Medical School. He is also a practicing internist at the Brigham and Women's Hospital. Dr. Figueroa wrote a commentary on Dr. Kim's piece. Welcome, Jose.
Thank you for having me.
So, Hyunjee, can you start off by please telling us about the genesis of your study and your interest in climate as a health economist?
So actually, it's based on my personal experience. So I live in Portland, Oregon, known for mild summer. So actually, many houses and buildings here do not have air conditioning units. And it was 2021, it was a June. We had record-breaking heat waves for 3 days, and the temperature rose to 116 Fahrenheit, which is 45 or 46 Celsius. And that was really stressful to me because we had a newborn baby. My son was 4 months old. And fortunately, we did have AC unit, but we could not lower temperature as much as we wanted because all of us, including our neighbors, were so scared of power outage. So we were trying to conserve energy as much as possible. And we could not go outside at all, and street was empty. And by the day 3 during heat wave, we couldn't stay home anymore. Like newborn baby, we have to go out. So we drove neighborhood with AC on, and it was like again empty. Except there was one guy who was walking really, really slowly on scorching asphalt. And I think he was an unhoused person, and he was pushing his cart with all of his belongings really, really slow. And he was wearing really thick black leather jacket with jeans. And that image really stuck with me until now. I vividly remember that image. And I just remind me like heat waves and extreme heat so detrimental to all human beings. But when you have so little, it's worse for you. And this experience actually was the reason why I started this line of research.
Well, that's a very dramatic introduction to the topic and your interest in it. What data and outcomes did you focus on in this study?
So here the research question is, let's find out the relationship between heat waves and adverse health events among dually eligible individuals. So to answer that question, we use two main data sources, claims and weather data. As for claims, because our study population had both coverage of Medicare and Medicaid, so we used nationwide Medicare and Medicaid claims to capture their adverse health events. And we linked that to weather data. We used daily temperature and vapor pressure from DAMAT. So DAMAT is incredible data source managed by the NASA. We loved DAMAT data sources because it has really detailed data. So for example, for daily temperature can be mapped at 1 kilometer by 1 kilometer grid across all the US, which was really amazing. So we converted that to the zip code level because that was the unit of our analysis. Outcome-wise, we looked at hospitalizations, emergency department visits, mortality and nursing home entry. And within hospitalization and ED visits, we looked at two different categories. The first one was heat relevant ED visits or hospitalizations. So those are the visits caused by conditions relevant to heat wave, but maybe not necessarily caused by heat wave. So that includes like electric imbalance, dehydration, excessive sweating. The second category was heat-specific ED visits or hospitalizations, and those are more conditions directly caused by heat, also including heat stroke.
So that's a good summary of your approach. What were your main findings in the study?
So, not surprisingly, during heat wave, those adverse health events all increased except nursing home entry. But it was more interesting when we did subgroup analysis. So, for example, we looked at the impact of heat wave on nursing facility residents because these are the population with so many health conditions, frailty, and then cognitive physical impairments. And fortunately, we found the heat wave had less impact on this population, and that was surprising. But that sort of makes sense because these nursing facilities are strictly required to keep indoor temperature to certain range of temperature. So I think that's why the nursing facility residents were not affected by heat wave that much. Another interesting finding was we look at the subgroup analysis by region of residence. We found this negative impact of heat wave was concentrated in the West region, including California, or Pacific Northwest, including Oregon, Washington, Idaho, known for mild weather. That made me think people here may not be well equipped for extreme heat, and maybe that's why people here got more affected by heat wave.
Thanks for that summary. Jose, could we ask you to highlight the main takeaways from the study from your perspective and let us know if any of the findings surprised you?
Yes, happy to. So my first big takeaway is, as was already mentioned, is that the findings of this study, unfortunately, are not surprising. But to me, they instead serve more as a reminder, a painful one. And that reminder is that whenever we face any moment of crisis, whether it be a major pandemic, an economic shock to the system, or an extreme weather event, in this case being a heat wave, the most vulnerable people in our society are the first to suffer, the first to experience hardship, and concerningly, in this case, more likely to die. And the second big takeaway is that the costly avoidable acute care use and the deaths that were described seem entirely preventable to me. And they are preventable very clearly from the example of the nursing home residents. They are preventable if we protect people from heat waves. And, we should note that nursing home residents are, on average, sicker people, much more likely to have complex multimorbidity, much more likely to be frail and have cognitive issues and functional limitations. And yet they were more likely to be shielded from the effects of heat waves. And so to me, we should really be talking about how do we protect people, including the most vulnerable people in our society, from the effects of extreme weather events, including heat waves and other weather-related events.
So, Jose, that really then speaks to the role of policymakers, health system leaders, clinicians, community leaders. What do you see as the implications for those audiences who might be able to take some of the steps to protect the people who are most vulnerable, like you described?
First thing I'll say is that I think we all, across all sectors, we all have a responsibility to protect everyone, including specifically the most vulnerable among us. And I think you can look at different sectors to play different roles. And CMS and the federal government can help push a lot of these different stakeholders to sort of come to the table and do what they can during these heat waves. So, for example, Medicare Advantage plans is half of the dual eligible population are enrolled in Medicare Advantage plans, which receive monthly capitated payments from CMS. And right now, CMS allows Medicare Advantage plans to invest in supplemental services, supplemental benefits for their beneficiaries if they think it can help. And in this case, there is an incentive for Medicare Advantage plans to provide access to cooling technologies or services that can shield people from the effects of heat waves, because they will see the downstream reduction of potentially avoidable acute care use. there should be an incentive for Medicare Advantage plans to be doing this. So there's an economic argument there. Now, for the other 50% of the dual eligible population, they're in the traditional Medicare program. And in that case, we should look to the most dominant form of care. And that currently is through alternative payment models, specifically the Medicare Accountable Care Organization. Similarly to the MA plans, there is an incentive for Medicare ACOs to invest in strategies that reduce costly, avoidable acute care use. And so we should think about ways for CMS to allow, like MA plans, for ACOs to invest in potential supplemental benefits, including access to cooling technologies like air conditioners for these socially vulnerable populations. Now, for the clinicians, beyond offering preventative advice, clinically, they should be doing a lot of things. And that, I think, we're placing more and more emphasis on ensuring we're adjusting medications, including adjusting diuretics, blood pressure medications. And then, increasingly, we should be thinking about having healthcare practices engaging with social service organizations for some of their most socially vulnerable populations to ensure that they can be connected to resources, including the ability to find ACs for many of these people, or including having access to supplemental coverage of things like helping pay with electricity. Because one thing I should say is just because you help someone get an AC unit doesn't necessarily mean that they'll be able to afford the electricity that comes with blasting it during a heat wave.
Thanks. Those are important implications that I think give our listeners a lot to consider. Hyunjee and Jose, at the end of our podcast interviews, we like to ask a couple questions of our guest authors. And Hyunjee, I'll pose the first question to you. What's the best advice you've been given about your career, particularly for developing policy-relevant work, such as your study in JAMA Health Forum on health-related events?
So it was about 5 years ago. I spent over 3 months on writing a grant proposal on dual eligible special needs plan. It's called DSNP. And unfortunately, that grant wasn't funded. And I was very, very disappointed. And I felt like the 3 months I spent was wasted. Then my mentor here at OHSU, John McConnell, told me, Hyunjee, I'm sorry your grant wasn't funded, but I'm pretty sure the knowledge you got while writing that grant will be used some way, somehow, sometime. And he was right. I used that knowledge a lot in my artworks. I realized in policy world, the important topics and issues keep changing and evolve. And sometimes I have to dive into new topics and learn a lot of things. And that comes as a formal grant writing for me. And sometimes things don't work out. But that's okay because, and this advice, like the knowledge you get somehow will be used and will not be wasted, keeps me going.
Sounds like a great mentor. Jose, I'll ask you a question which is kind of unfair, in a election year like one we're in. But putting that aside, what is the biggest change you expect over the next 5 years related to health policy?
Yeah, that is a very hard question. But I think if I take a step back and look at, in my opinion, what are some of the most concerning trends in healthcare, and then from that angle, what can we think about from a health policy perspective to be able to deal with changes of our healthcare system? And the trends, I think, are two interrelated issues, which I think, in my opinion, are both very critical. The first one is we're seeing ongoing privatization of our healthcare system. From insurance coverage, we just talked about Medicare Advantage, that is growing, to private equity playing a bigger role in healthcare, to increasing consolidation of healthcare systems. And then the second big issue, which again is related, is affordability of healthcare, increasing costs and prices for all healthcare services, increasing premiums, and drug affordability being a major issue. And so I expect that much of our healthcare policy will be trying to figure out how best to regulate the healthcare industry and the different players. And my biggest concern right now is that the ability for us to regulate the healthcare industry changed significantly this summer, and that was through the when the Chevron doctrine was overturned, which historically has given deference to different agencies, whether it be the CDC or CMS or FDA, in decision making whenever laws were a little vague or not necessarily clear. And that power now to make calls when, it's not necessarily clear what's legal lies now with federal judges, and they may or may not be in the best position or have the right expertise to make the right call. And that's something I think that would be really important to watch over the next 5 years.
Thanks to our guest authors, Dr. Hyunjee Kim of Oregon Health and Science University and Dr. Jose Figueroa of the Harvard Chan School of Public Health. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.